we're going to invite Haley Cote to share this information with you all. Haley, would you please come to the stage? Haley has earned a doctorate in pharmacy, completing her residency at Community Medical Center in Missoula, working on various aspects of care improvement and direct service. Today, Haley is a member of the population health team at Blue Cross Blue Shield of Montana, where she focuses on chronic disease management and maternal and infant health. I'm so pleased to welcome Haley into this space because she's actually the first representative of a private payer insurance that we've had at the conference ever. So yeah, let's give her a round of applause. Because as advocates, we know that our relationships with health insurance companies, whether they're public or private, they're important. We need that partnership to enhance these systems so that we can increase access to care. And we know that in maternal child health that there are some big things brewing in Montana that we'll hear more about tomorrow. That is, something we're grateful to partner on. So we're so proud to have Blue Cross Blue Shield Montana as one of our sponsors for this event and also as our partners in doing some of this work. And yeah, thank you. Let's welcome Haley, and excited to hear this. Thanks, Haley.
All right, can everybody hear me okay? I guess I better get my clicker here. Okay. So here are my objectives. As Amy mentioned, I'm just going to kind of give an overview of the data, but I'd like to kind of present it in a more of a population health approach. I'm going to kind of go through here. Disclosures, this is really more probably a disclaimer, which I always joked that I should come with one of those, and now I do, so that's pretty exciting. But I just want to say that the data being presented is all publicly sourced data. It's not specific to Blue Cross Blue Shield Montana membership or any of our databases there. And then there's also this is sort of our long disclaimer that we have, but the opinions and recommendations are my own, not necessarily on behalf of Blue Cross Blue Shield Montana. This is me and my dog Wheezy, so I thought this would also be kind of a good time to introduce myself. I do not have any kids. I just have my little dog Wheezy. I joke that I'm a professional auntie. You may be wondering why someone from the health insurance company and who's also a pharmacist is up here talking to y'all. So just to give you a little bit of my background, I started working with the perinatal population in my residency after I graduated pharmacy school in the NICU, where I spent some extended time caring for patients, neonates and birthing people during that experience. I then moved my clinical practice into the primary care setting and primarily did chronic disease management. And most of the work that I did with the perinatal population was for managing their chronic diseases or gestational diabetes, but I also had a pretty heavy consult service with our primary care providers. And the majority of those consults were actually around medication dosing in the prenatal and postpartum period. A lot of questions around that, so that was sort of where I spent most of my time during that work. In December of 2022, I then joined Blue Cross Blue Shield on the population health team and had the opportunity to start as a clinical programs manager. And admittedly, when I was asked to kind of lead or sit on these maternal and infant health work groups, my first thought is like, it's not a lot of role for a pharmacist there. And that's, again, why I'm explaining all this to you. It turns out that it has been sort of some of the heaviest work I've done, and it is something that I've become very, very passionate about, and I'm really honored to be here today talking to you about our population health approach to perinatal mental health. I also just want to say that at times during this presentation, I will use gender terms like woman, female, mother. And I just want to acknowledge and respect that not all birthing people identify this way, but this is the way that at times it is presented in the data or in the literature, so it's subsequently presented in my slides that way as well. The last thing I want to just say, again, all these little disclaimers about myself, I've had the opportunity to listen to Dr. Stiffarm present multiple different occasions, and she does a great job of reminding us that we need to take a strengths-based approach And at times I will be presenting data about specific disparities or vulnerabilities within our population. And I just want everybody to know that I'm not trying to take I'm trying to take a strength-based approach there, but also just point out some opportunities that we have to support some of our more vulnerable populations within the state. So I think that, I'm gonna try not to get my shoe stuck in this little thing here, that would be really cute. So the majority of people in this room know that, in the United States, maternal morbidity and mortality is rising. And actually in Montana, we have a higher maternal death rate than the United States average based on our 2022 data. We know that perinatal mental health conditions are the most common complication of pregnancy. And according to the CDC, mental health conditions account for 22.7% of pregnancy-related deaths. And suicide and overdose are some of the most common causes of death in the postpartum period. We also know that 1 in 5 birthing people experience a perinatal mood and anxiety disorder. And in some cases in the literature, you'll see this presented as 1 in 7. It depends on what that definition of perinatal mood and anxiety disorders is. But we also know that when we think about those, we often think about postpartum depression. But we know that 2/3 of depression actually presents prior to delivery, which tells us that we really need to be screening our birthing people prior to conception and in that prenatal period, not just after in that postpartum period. And the good news is during pregnancy, we have a lot of opportunity or a lot of touch points to be screening people. But in Montana, we do have a proportion of patients who aren't receiving adequate prenatal care, and about 13.6% of birthing people in the state aren't receiving adequate prenatal care as of in the 2022 data. I've listed some risk factors here, and if anybody has had a chance to listen to Dr. Greenberg's presentations that were recorded prior to this session, she does a great job of reviewing the risk factors and the diseases overall. So I don't want to touch on these too much, but there's a couple I want to point out because I'm going to be continuing to talk about them through the presentation. And the first is that personal history. We know that if patients have a personal history of perinatal mood or anxiety disorders or a personal history of any mood disorder, they're at an increased risk of having a perinatal mood disorder during that pregnancy. So we really, again, need to be screening patients prior to conception in the primary care setting and in that prenatal period, and also screening for that personal history as well. And then family history of mood disorder or PMADS. And I just thought this was interesting because in some of the literature that I was reading, there's about a 50% heritability of postpartum depression, which is much higher than major depression, meaning that about 50% of people with postpartum depression seem to have some type of genetic disposition. We don't know what genes those are or what's contributing, but just notably that that's higher than major depression, I think is sort of an interesting finding. So now to talk about what is population health, I just want to make sure that we kind of level set and let everybody know what that is. So population health is really promoting the health and clinical care delivery across an entire population. So historically, we might focus on managing that single patient that presents to the clinic, and this is really implementing interventions that are going to support our entire population. So from a payer standpoint, it's really looking at entire communities. It's not just looking at our membership, and that's a lot of what we're doing at Blue Cross Blue Shield is looking at the entire community and how might we be able to impact care delivery for that whole community. We also know, I don't know if this is a pointer or not. I think it is. We also know that we used to always kind of focus on that clinical care. That was the thing that mattered the most. But we know that actually social and economic factors in the built environment account for about 50% of a person's health outcomes. So if we don't address those, we're not going to see any improvement in the health outcomes of our patients. So when we're taking a population health approach, we're really looking at those other factors that influence health and taking sort of looking at it through a health equity lens to identify potential disparities or populations that may be underserved and trying to improve outcomes by addressing those. At Blue Cross Blue Shield, our population health approach is really centered on supporting our providers and advanced care teams. So a lot of what I do, and I've met some of you in some of these travels, is I travel around the state and try to learn about what are different practices doing, what's going on in primary care, what does care delivery in that community look like, and we try to help support those providers or those health systems based on the needs and the challenges that they're seeing in that community, rather than implementing or saying, Blue Cross Blue Shield recommends that everybody in Montana implement this one care delivery thing. We realize that that's not going to work. So a lot of the work we're doing is really specific with each clinic, and we would love to talk to all of you and learn about what everybody is doing. And I know that Stephanie's going to be kind of working after me, and we'll get to hear some more about that too. And then we also work to engage patients or our members in our care when we're specifically talking about our Blue Cross Blue Shield membership. Our tables over there, we have our employer-facing population health team that focuses on our membership, but also helps employer groups work with their entire panel of employees, and they're doing a lot of work also in trying to support maternal and infant health through that avenue. And then we also have our care management team that helps support our members directly. So as we sort of started down this road of maternal and infant health, or as I sort of started down this road of the data in maternal and infant health, of course we look at our overall disease prevalence. As I mentioned, we look at our membership and we look at the overall prevalence in the communities, but we really wanted to find out, where are birthing people most vulnerable? So we looked at the maternal vulnerability index, and by show of hands, how many people are familiar with this? Okay, good. So the maternal vulnerability index was actually developed during COVID, and it basically is a tool that helps identify where, like, geographical areas where birthing people are at an increased risk of a negative birth outcome. And so here's Montana, and the maternal vulnerability index is the shading. The index takes into account 6 different domains to build like the overall score. The reproductive health domain is things like access to family planning and prenatal care. The physical health domain is the overall health of that population within that community. So chronic diseases, non-communicable diseases, and STIs. Mental health and substance abuse is the prevalence of those mental health and substance use disorder diagnoses, as well as access to care, mental and behavioral health care. General health care scores are things like access to care, affordability of care, quality of care, insurance status in those communities. Socioeconomic determinants are things like employment status, poverty, crime. And then physical environment are, transportation, housing, not necessarily in this, but like things like access to internet. And what the index does is it takes into account all those different scores, and you can see at the bottom on Montana, those are each different little score. It might be hard to see with the lighting of the slides. And then it creates an overall vulnerability score. And the higher the score, the more vulnerable that population is. So the darker the shading, the more vulnerable the population is on this map. You can see overall in Montana, our score is considered to be very low, but we have some areas in the state that are much darker shading, that are at actually much higher vulnerability scores. And we also know that there can be some portions of the population, even in these areas that might have lower vulnerability, that are still at increased risk that aren't necessarily captured. So it's not perfect. We really need to be able to dig into all this data and look more closely at each community, but it's sort of a way to look and decide where to start as we're digging into the data. An interesting finding, I don't know if it's an interesting finding, but it's a finding, I guess, in the overall maternal vulnerability index across the United States is that birthing people living in rural communities have higher vulnerability scores compared to people living in more urban communities, and you do see that here. And you also see, I'm waving this around like there is a laser, but so bear with me as I do that. And then also our reservation communities tend to have that more darker shading, so higher vulnerability there. So to that point, when we bring in who is the most vulnerable. So this graphic here is probably, again, a little bit hard to see, but it's taken directly from the MVI report. And it shows each of the different regions of the United States. And you can see on the right-hand side of the screen here that our Black, American Indian, and Alaska Native birthing people are scoring about 10 to 12 points higher than white counterparts. And you can see on this graph here, or on the pictures as well, that our Black, Alaska Native, and American Indian birthing people in all of the different regions are scoring higher, and that is contributing to vulnerability, which shows the impact of structural racism on our maternal vulnerability and those outcomes. Interestingly, in the West here, which is where we are, the gap in that vulnerability is higher than in any other region. So there's an 18-point difference for Alaskan Indian, American Indian, Alaska Native birthing people relative to the regional average. And when we dig into the data that's contributing to that, there are multiple different factors contributing, which indicates that we really need a multi-dimensional approach that's also culturally safe to be able to identify or implement interventions to support these populations. So this map again, this is, again, the same map, but what I've tried to do is call out each of the different communities that have the highest vulnerability. And then those circles there, because we're talking about mental health, the circles are the proportional mental health scores of each of the communities. And I wanted to show this. I also picked some that have a low overall total vulnerability, but a higher mental health score. And I wanted to show this as you can see that in each different community, there are different contributors for that vulnerability. For example, in Roosevelt County and Lake County, those scores are almost identical, but the scores of each different domain contributing to that overall score are very different, indicating that an intervention in Lake County is going to need to be different than the intervention in Roosevelt County. Or if we look at like Bighorn and Rosebud, you can see that the general health care scores are both really high, indicating that there might be poor access to care or poor affordability of care in those communities. But then the overall score in Bighorn County is much higher because there are multiple different factors with higher scores than in Rosebud. I also should point out that there could be some like smaller community organizations that aren't necessarily reflected in this that could be missed. So there's definitely limitations to this, but it's a place to start. So now sort of moving on into the data itself and what's feeding those mental health scores. As Amy mentioned, there are some limitations to the data and what's reported and what we're able to find. So a lot of this that I'll be presenting here is through literature searches and then any available data that we have. And because having a personal history of a mental health condition, it puts us at increased risk of a perinatal mental health condition, I will try to report the overall general population disease prevalence in each of these slides. You can see here in Montana, about 24.5% of adults report history of depression, and when we can break that down, it's that score for our females of childbearing age is higher than the average population. So again, that indicates our need to be screening people prior to conception in that primary care setting. Below that, we show from the PRAMS database, which is a survey that's sent out to patients postpartum, and ideally completed 3 to 6 months after delivery, but can be up to 9 months after delivery. It's a self-reported survey, and based on our most recently available PRAMS data, you can see here that in Montana, the rate of birthing people who are reporting symptoms of depression is higher in the pre-pregnancy and during pregnancy period relative to the United States average, but it is like slightly lower, like very slightly lower in the postpartum period. When we look at the literature, we see that in the during pregnancy or that prenatal period, the incidence of depression is about 14 to 23%, and in the postpartum period, the literature reports about 11 to 17, although some Some literature reports are about 20%. So you can see in the, in our pre-pregnancy and during pregnancy overall state rate, that is close to what the literature is reporting, but in our PRAMS data for our postpartum depression rates, that's actually a much lower than what we're seeing, or close, but still lower than what we're seeing in some of the literature reports. And part of that could be the time when the survey is completed. We know that there is an increased risk of postpartum depression later on in the postpartum period. So if these surveys are completed early, that could be a potential limitation, showing a lower reported depression symptoms in that population. I also just kind of wanted to point out some of the demographic data where we can see that American Indian, Alaska Native birthing people and those in the lower income stratification are reporting a higher incidence of depression across all periods. And also younger patients tend to be reporting higher incidence of depression symptoms as well on this data set. This data is good. I don't want to suggest it's not good data, but there are some limitations to this as well. Some of that is recall bias. So patients may forget by the time they fill out the survey that they had symptoms earlier on, or response bias. So if the results are weighted, but there's the potential that someone who might be experiencing symptoms of depression might be less likely to fill out this form and return it. And then also, the overall sample size, it's just a proportion of the population, so the sample size is low. But again, the data is weighted in some of the newest data that we have available for us. So those are all self-reported depression screens. So we know that if we're gonna manage depression, that depression actually has to be diagnosed and then treated. And to get depression diagnosed, you have to be screened at a provider's office. So then we can look at prenatal care. Again, there's a lot of opportunities for our birthing people to have depression screened. And in Montana, on average, our birthing people are getting about 11 prenatal visits per each live birth. ACOG recommends about 12 to 14, so it's close. And the majority of our birthing people are receiving adequate prenatal care. But again, there's a subset of our patients in the state that aren't receiving adequate prenatal care, so are having fewer opportunities to be screened. And again, we want to make sure that we're also supporting those patients outside of the perinatal period. We don't have great data of who's seeing a primary care provider and having screenings and things like that there. But there's also some concern that if you were having a perinatal mental health condition, you may be less likely to seek prenatal care. And also, so not only are you maybe at a greater risk of having those perinatal health conditions, but you're also at a greater risk of not being screened. So then we see self-reported postpartum follow-up. Again, this is from our PRAMS data. And actually, our postpartum follow-up is really pretty good. And I kind of showed it based on each year here because I was surprised to find that there wasn't much of a change around COVID. I was sort of expecting a bit of a dip in the people presenting postpartum care in that period of time, but we don't see much of a change there. The thing to note, though, is in the birthing people who are reporting receiving postpartum care, they aren't all reporting having their being screened for postpartum depression. So there is a gap there. The other thing I want to point out is this self-reported postpartum care data is a little bit higher than what we see based on claims data. Claims data also has its own limitations, so neither are perfect. But just, again, being aware of that non-response bias, and maybe someone who has not received postpartum care may be less likely to respond to these surveys. So just something to be aware of. The other thing I just wanted to address that I think can be at times maybe somewhat discouraging. We look at the Montana report card from the Policy Center for Maternal Mental Health, and you can see we get a D+, but part of that is because we get an F for the screening and reimbursement. And part of how they track that is because they're using HEDIS data. So HEDIS is a tool that payers use to measure the quality of care across multiple different domains. These two specific HEDIS measures, Prenatal care depression screening and postpartum care depression screening are both electronic measures, meaning that that data has to be sent electronically to the health insurance provider, meaning it has to be documented in a place in the chart where that's sent to the provider. It has to be coded in a way that that's sent to the provider. And we know, you can see, here, there's only a few commercial plans that are tracking that data in the state, but like postpartum depression screening of 8.1 according to this HEDIS data, but then you look at self-reported depression screening of 85%. We know that more than 8.1% of patients are having their postpartum depression screened. We're just not necessarily receiving that data. So the score, I don't think, is really reflective of what's actually going on. And as an example, in some of the work we do, as I said, we sort of go around and we figure what's going on in the state and what might we be able to share with other practices across the state. So we talked to a pediatrician office in Billings who is screening all of the infants' parents for postpartum depression. And those results aren't necessarily going to be added to that parent's chart. The pediatrician doesn't necessarily have access to the parent's chart. They do a phenomenal job. They've created care pathways where they have a referral system, if that screen is positive, where they can refer to different primary care practices, get that patient in with primary care, or get the patient connected with the OBGYN. They have a pathway if the patient is at risk of suicide. So they're doing a phenomenal job of screening, but that wouldn't be reflected in this HEDIS score that's feeding the results. So not to say that there's not work to do, but I think that F might be a little bit unfair. What? Yeah. And it's hard to know, what the actual rate of depression screening is, but again, it's more than 8.1. We work with primary care practices a lot who have implemented universal screening for depression. So they're screening every single patient who walks in the door with a PHQ-9, and we have some of our quality programs that actually pay the provider incentives based on the number of patients they're screening. And we see that those results are consistently low. If they're screening 100% of the people that walk in the door, we should be, seeing really high rates, but we're not, because it's not documented in that they didn't fill out that one specific checkbox in the chart, or they didn't code that they didn't send that code for that depression screening. So this type of data is really hard to identify who actually is being screened, but I'm confident it's more than 8.1% of people. So, as a pharmacist, it's important to talk about treatment, of course. I move my hands so much I'm afraid to leave my water bottle open and then ruin the day for everybody. So, as a pharmacist, it's important we also talk about treatment. So, to have a good outcome, we need to be screened, diagnosed, and then treated for perinatal mental health conditions. And this study, which is a systematic review, evaluated during the antenatal and postpartum period the rates of depression diagnosis, treatment adequacy, and disease remission. And the author's goal was to identify potential gaps in that treatment cascade. So where are we sort of falling behind here? One thing I want to point out, again, I'm a pharmacist, so adequate treatment in this study was defined as at least 6 weeks of daily antidepressant use at a minimum of the recommended starting dose, where we know that in most cases that dose is going to need to be titrated. Starting doses of antidepressants are usually for tolerability, and the dose needs to be titrated. Again, this was the most common consult I would receive, and there is a lot of hesitancy for prescribing these medications for people in the prenatal and postpartum period. And then the other treatment adequacy was at least 6 weeks of evidence-based psychotherapy. So they included 32 studies across the treatment cascade. And what they found was of the people who screened positive for postpartum depression, only about half of those actually received a diagnosis of prenatal or postpartum depression. Then when they looked at the treatment rate, they found that about 85% of people across the continuum of the pregnancy are not receiving any treatment. So that includes those who aren't diagnosed, but those who are also diagnosed and not receiving any treatment. So that's not adequate treatment, that's any treatment. Then they looked at treatment adequacy, and you can see there were few studies that actually evaluated treatment adequacy in the way that these authors defined that. But the one study that met their criteria had an adequacy rate of about 8.6%. They didn't have any treatment adequacy studies for the postpartum depression period, so they used sort of general population-based estimates of 6.6% treatment adequacy in that population. So then they looked at the response rate in all these studies, and but in the response rate studies, we know that those patients are receiving adequate treatment, or adequate treatment at least is defined by this population. So they used their treatment adequacy findings and the response rate findings and found that only 4.8% of women with antenatal depression and 3.2% of postpartum depression will actually receive remission. So again, we have to screen, diagnose, and then treat that depression. And there is, again, a lot of hesitancy, both from prescribers and also from our patients. Patients don't want to take anything that could potentially harm their infant. So I did include some resources here. And the top one has some really excellent, has a great overview for providers, but it also has some really excellent resources that patients can refer to that help them be able to understand their treatment decisions and the safety of their treatment decisions and help them with shared decision making. So I encourage everybody to check out that resource. So moving on to anxiety. We really don't do a great job in the United States of tracking anxiety prevalence at all. But it's estimated, according to the National Center for Health Statistics, that about 15% of adults have experienced anxiety symptoms, and females are more likely to experience anxiety symptoms. And I think if you would ask like a group of millennials, or if I were to poll my group chat of people my age, that would be like 100% anxiety. That 15% seems low, at least based on the crowd that I hang out with. So we can see though that in the general population estimates, there's about it's estimated that about 33% of the population actually experience anxiety symptoms. So again, just to kind of point out that the data we have is a little bit difficult to interpret. This graph, I made it more difficult to interpret, didn't realize was I copied it in until I was working through these slides that it's backwards. So here is the most recent, there's the furthest away. But this graph here is adults reporting anxiety symptoms. And again, this is in the general population, not necessarily the perinatal population. And this survey was developed during COVID to be able to more quickly identify changes in mental health during that period of time. And they've continued it to try to identify pandemic recovery, where they're sending, it's a web-based survey where they do a modified GAD-2 or a modified depression or anxiety screen, and they send it and patients fill it out, and then they get it and they report it off in these like 2-week chunks. And you can see over the course of a year, because we're backwards again, we have had improvement in report of anxiety symptoms. But again, this is based on a GAD-7, so that's anxiety at that time. So between July 25th and July 22nd of 2024, 19.2% of people in Montana who took the survey reported having anxiety symptoms. I looked again before I came here, and the last 2 weeks of August, about 15% of people had reported anxiety symptoms. So we are going to see a little bit of fluctuation. The good news is, as you can see, we're sort of spot on with the rest of the United States. Be interested to see what happens like November, as right now, as we're all working toward elections and getting a lot of phone calls, what that might look like. But it is one way that we can sort of track changes in anxiety symptoms. So then when we're looking at anxiety in the perinatal period, the data is even more variable and more difficult to track and sort of identify and pin down, like how many people actually have this. So to the point of variability, it's estimated that between 8.5 and 20% of birthing people have an anxiety disorder. And the most common are generalized anxiety disorder, OCD, social phobias, and panic disorders. So this estimate of 1 in 5, That's sort of what we think what it is. But we also know that that perinatal anxiety is a strong predictor of perinatal depression. And there was one study that found that 2/3 of birthing people had experienced a comorbid condition in addition to their perinatal depression, and 82.9 of those comorbid conditions were anxiety disorders. So they're extremely common, especially in patients who are experiencing other perinatal anxiety disorders. PTSD is we estimate 1 to 4% of birthing people, but we're not screening everybody for PTSD. So this is probably really underdiagnosed. There was a longitudinal study that did screen patients in the prenatal period for PTSD and found about a 17% incidence of positive scores in that population. So that's 17% is a lot higher than 1 to 4%. We know things that increase risk of PTSD in the perinatal period are, previous complications of pregnancy, any, difficult births, historical traumas. We have a large population in the state with historical trauma. But again, we're not screening our patients in the prenatal period or in the primary care period. So it's, or in primary care, I should say, for PTSD. So it's not only underreported in this population, but in the general population. So I think we could do a much better job of screening to be able to identify those who are at risk of a perinatal mental health condition. And then OCD the same. We know that OCD is more common in the postpartum period than in the prenatal period. But again, we're not routinely screening for it. Oftentimes, OCD might be diagnosed as generalized anxiety disorder, or we're maybe not getting so specific. So there was one study that estimated up to 17%, 16.9% of people in the postpartum period experienced OCD. So again, our data is sort of lacking because of some of it is to do with our practices in screening and diagnosis of these conditions. I guess the takeaway with anxiety is really, we need to be screening people. We need to be starting to look at in our perinatal care and also in our primary care, making sure that we're doing a better job of screening for some of these conditions. So then we move to bipolar disorder. We know that it affects about 4.4% of the general population. We don't have great data on bipolar disorder in the perinatal period. For anxiety and bipolar disorder, we don't have specific data for Montana in the perinatal population either, which is why I didn't show that. I wasn't just withholding information. But we know that comorbid mental health conditions are really common in this population. Specifically, anxiety is really common in this population. And we also see a high incidence of comorbid bipolar disorder and substance use disorder. And we're not always screening our patients with substance use disorder for bipolar disorder after they get that diagnosis. So that's also kind of an important takeaway, is making sure that we're treating the whole person and we're screening for other comorbid mental health conditions that could be happening. We know that bipolar disorder increases our risk of suicide, and we know that the prevalence of bipolar disorder in our birthing people without any previous psychiatric history is about 2.6%, although some reports a little bit higher because the onset of pregnancy tends to also be the onset of bipolar disorder, and then all of those hormone changes can also be contributing. So there's some data to show that the prevalence of episodes of bipolar disorder is actually much higher in this population than in the general population, although the still kind of trying to flush that out, why that might be, or what is contributing to that in the data. But notably, 22.5% of patients who screened positive for perinatal depression were actually found to have bipolar disorder. So it's really important that as we're screening patients, that if they screen positive for depression, that we're also ruling out bipolar disorder, as if we start an antidepressant, in some cases that can induce mania, which can be really dangerous, detrimental. And I don't think that is being done very often, that we're screening for both of those things when we have that first positive. We also know that in patients with bipolar disorder diagnosed prior to pregnancy, there are a 54.9 recurrence or prevalence of recurrence during that pregnancy. So if we're caring for patients who have a history of bipolar disorder, we really need to be making sure that we're supporting them, monitoring them for potential recurrence in those episodes during the pregnancy. And also, people with bipolar disorder are more likely to experience postpartum psychosis, and it's estimated that about 70% of people with postpartum psychosis actually have bipolar disorder. So again, this is a population that we need to be monitoring very closely during that entire prenatal and postpartum period, and again, from a population health standpoint, also prior to conception in primary care. So now looking at suicide, and we know that the suicide rates in Montana are the highest in the nation based on this 2022 data. We've been top 3 highest for the last 3 years. This graph here is actually from 2021 data, so it doesn't exactly match that top, but it's from the county health rankings and roadmaps data. And the populations that I've circled on the map are those populations that I showed earlier that have those higher vulnerability index scores or have higher mental health scores on that vulnerability index. And then I've also just kind of pointed out, again, in some of our rural communities where there are less resources, our suicide rates in these communities are higher. I keep bringing up primary care, but I want to mention again that about 45% of patients who successfully complete suicide have seen a primary care provider within the month prior to that suicide. So that's important as, again, we're screening for depression. In many clinics across the state are doing like universal depression screening, and there is the suicide question on the PHQ-9, but that question asks about in the last 2 weeks, has anybody had thoughts of self-harm or suicide? But we're not consistently doing a great job of doing suicide risk assessment. And that suicide risk assessment with tools like a CSSRS are going to actually screen for lifetime history of suicidal thoughts or of suicide attempts. We can see that in our perinatal population, 8.4% of pregnancy-related deaths are related to suicide. That risk increases as we move into the postpartum period. And 34% of patients who complete suicide in the perinatal period have had a previous suicide attempt. So again, we can screen for PHQ-9 or we can screen for postpartum depression, but to really identify patients who are going to be at risk of pregnancy-related suicide, we need to be doing a suicide risk assessment in those patients as well. Oftentimes the feedback that we get is that there aren't resources to support those patients once that screen comes up, or that the staff is not trained to ask those questions. The suicide risk assessment questions are developed to be asked to the patient. It's not a form that you hand the patient. So there is some degree, the staff in the clinic does need to be comfortable actually asking those questions. And we, in my previous practice, did implement a universal suicide risk assessment policy in the clinic. There are some other practices doing that across the state. But in doing that, and in the work that we're doing trying to support primary care practices, we have developed sort of a list of resources. I've listed a few here that can be helpful, but some of these have like really great training resources for clinical staff to be asking the questions, they have actual pathways to manage the patients. And, I have to say, admittedly, in the primary care practice, it is hard when you have a patient screen positive and you don't have an option for them or you don't have anything to do. That is a really difficult place to be. But in speaking with that pediatrician, again, it's a pediatrics office. They're not trained to manage suicide in adult patients. But they have identified suicide and successfully managed it, getting that patient into care right when they needed it and getting them the resources that they need. So I think that if a pediatrics office who's managing the little babies can do it in our adult population, I think primary care and obstetrics can as well. So substance use disorder. This data in Montana, we have higher rates of substance use disorder than the U.S. population. Majority of that is marijuana, and you can see sort of otherwise kind of tails off a little bit lower. This map, again, county health rankings, I've circled on here, like Lake County, that's one of the higher vulnerability counties on that vulnerability index, and also one of the higher rates of drug overdose deaths. But then also Silver Bow County, that is a really low maternal vulnerability index score, but the highest drug overdose death in the state based on the 2021 data. So that kind of shows us, again, that score, that vulnerability score isn't necessarily perfect. This isn't necessarily only in the perinatal population, the map here, but there's a percentage of people in Silver Bow County who are at risk of drug-related overdose that aren't necessarily accounted for, just again, proving that we need to be digging deeper as we're making interventions to manage perinatal mood and anxiety disorders. We need to be digging deeper into the data and find out what is actually going on in the communities that we're implementing these interventions in. So we can look at pregnancy and illicit substance use based off the PRAMS data in Montana. This 8.3% of pregnant people in the United States reported using illicit substances during pregnancy, and that was from the National Survey on Drug Use and Health from 2022. They've actually stopped asking that question on that, or excuse me, that's from 2020. They've stopped asking that question on that survey, so that's the most recent data I have available is at 8.3%. But you can see, based on that, that score is lower than the birthing people who are reporting using illicit substances during pregnancy in Montana on that PRAMS data. A limitation of the PRAMS data is we don't know what substance it is. We also don't, we do have a breakdown in that US report, the majority is marijuana. So we don't know what substance that is. Again, if a person may be using substances, are they less likely to complete the response? It's hard to say. I reported it this way in that, you can see that sort of steep incline during the pandemic, but we are starting to trend downward, which I think is a good thing. And then the demographics here are similar to the demographics in the other PRAMS data that I presented. So the last thing as it relates to substance use disorder that I wanted to touch on is buprenorphine prescribing trends. Again, I'm a pharmacist, so I don't know how to not talk about this stuff. We know that buprenorphine-containing products decrease the risk of overdose, and they improve quality of life. They're safe and effective for the treatment of opioid use disorder. In pregnancy, the recommendation when we're talking about buprenorphine is generally buprenorphine alone, not buprenorphine and naltrexone, although there was just a recent really good study in JAMA that came out that did prove safety of buprenorphine and naltrexone in that population. I'm bringing this up because we know that these drugs are underprescribed in the general population and also in the perinatal health population. And there was a review here, or a couple reviews, that looked at the subset of patients who are least likely to receive medication therapy for opioid use disorder during the perinatal period. You can see, again, rural communities, non-white race, lower educational status. So again, there's this population of people who are at higher risk that we need to be putting our efforts to supporting. So the other thing is this X waiver. Does anybody know about the X waiver? Some people know about the X waiver. So in 2000, when they implemented the Drug Abuse Treatment Act, the government decided that if you're going to prescribe buprenorphine or medication therapy for opioid use disorder, providers had to go through this additional training and receive an X waiver or a specific certification on their DEA license to be able to prescribe those. And I think it was in good effort to have trained prescribers managing patients, but maybe a little bit short-sighted. The thought is it potentially has contributed to some stigma for patients even wanting to receive care because there's fewer providers that can actually prescribe that. But the other thing that it's potentially done is made it difficult for prescribers to be able to do it. So well-meaning prescribers who wanted to prescribe weren't able to unless they underwent this additional training and got this designation on their DEA license. And then, this is my opinion, I think it also contributed to prescribers being less comfortable prescribing these medications for opioid use disorder. And this is important, again, in the primary care setting especially. We had, in my previous practice, 1 prescriber out of 8 with an X-waiver license at the time I was practicing. And it was great because he could manage patients in the primary care setting for opioid use disorder. The problem became is when they were out of the office, like sick or just on vacation, and that refill came up, no one in the clinic could take care of that. No one in the ER could take care of that. So that prescriber actually ended up referring all of the patients out of the primary care setting because the system just wasn't set up for him to be able to successfully manage those patients. They actually relaxed the X waiver in 2021, which is why I've shown this graph here, where they sort of made the training requirements a little bit easier and more prescribers were eligible to be able to prescribe. And there was a study in 4 different states that was actually just published that found that there were more eligible prescribers, but they weren't actually prescribing. In Montana, we see that too. So in 2021 to 2022, there was no, even though those waivers were relaxed, more eligible prescribers, we don't see more buprenorphine being prescribed. And it's hard to say, I think that there are some prescribers who just didn't get the memo, they didn't know that was happening. But I think also patients, and part of the reason I'm talking about it today is to bring awareness to that's not a thing anymore. We may all be working with patients who have experienced that or some difficulty getting into that, but that's not a thing. In 2023, they actually got rid of the X waiver. So now anybody who can prescribe medications can prescribe medications for opioid use disorder. A former colleague of mine who was at the practice at the time that our other provider wasn't able to continue to practice has since started prescribing medication for opioid use disorder, and she admits she was really nervous and scared at first. She did some self-learning, she has some support in her clinic, and now she's successfully managing multiple patients for their opioid use disorder, which I think is a huge win, and I think there's an opportunity for that all across the state. I've included a couple resources here. One of them is Dr. Greenberg's second installment of the Perinatal Mental Health 101 that was done here. Again, if you haven't had the opportunity to watch that before you came, I would suggest you do. It's excellent. But also the other thing that I did not list here is the ECHO programs. There are multiple different ECHO programs that help with prescribing for opioid use disorder, both in the general population and in the perinatal period. And those ECHO programs, even if it's a New Mexico ECHO program, you can still join that program. And if you have questions about a case, you can submit those questions and get support from colleagues. There's an app called iEcho. There's also the Indian Country ECHO program that has some really great tracks as well. So I'd encourage any prescribers who are looking for that, or if you're working with prescribers who want more information, that they join those. This is my clicker here. Alcohol use disorder, I just wanted to point this one out, is in the self-reported alcohol use disorder on the PRAMS data is actually, the demographics are opposite of any of the other data that we've seen, and that patients who are white, of higher income, and with private insurance are actually more likely to report using alcohol during their pregnancy. Again, a limitation of this is we don't know what that means. It's like, are you binge drinking? Are you drinking a little bit every now and then? So it's not super telling data, but it's just sort of interesting, that finding. And then when we look at excessive drinking in the state, our counties with the lowest vulnerability index have the highest percentage of excessive drinking in the state. So like Gallatin County has actually the lowest MVI score and has the highest excessive drinking score, where Bighorn County has the highest MVI score and one of the lowest excessive alcohol use scores. So, Gallatin and Missoula County are college towns, but maybe that has something, I'm not sure. Probably does. I also put Butte in there because that's where I'm from, and people talk about, the number of cocktails we drink, and it's a lot. But again, not to continue to pick on Butte, but that said, that Silver Bow County was that county with the highest rate of overdose deaths as well. So just kind of another important predictor of maybe there needs to be some additional support for substance use disorder, including alcohol disorder in that community. And then the last here is intimate partner violence. And we know that this increases our risk of perinatal mental health conditions and also suicide. This is, again, the PRAMS data, and there's few people responding yes to these questions, so the data is pretty suppressed. This is the only demographic we can see it in. But notably, in our PRAMS, our birthing people reporting having experienced intimate partner violence relative to the US is higher in Montana. And then you can see that the rate in the American Indian Alaska Native population is much higher. Again, indicating that we need to be supporting these communities. I put here, the different breakdown of intimate partner violence by type, but there's also evidence to say that intimate partner problems increase our risk of perinatal mental health disorders and suicide. So those are maybe nonviolent conflicts like arguments, divorce, things like that. So we're screening for violence, but we also, I think, need to be making sure that our birthing people aren't also experiencing other general intimate partner problems. All right. So now I want to move on from more of the data prevalence to some of the access to care. And I'm going to have to kind of go quick because this is my favorite part, so I can get kind of yappy, but I guess I did that before. And so this is sort of those factors that influence health. That sort of bottom graph, that bottom piece of that graph that I showed on the population health chart, the things that we need to be doing to really improving health outcomes. So access to care is one of them. We know that in Montana, birthing people have to drive further to receive care. And imagine the stress of that, being alone or having to travel to a different community where you don't know anybody, you don't have any social support. Even the idea, I think, again, I'm not a birthing person, but I'm a person with anxiety. So I can sort of imagine if I were, I get afraid of tick paralysis if I hike, which is like a very rare thing. And I can imagine if I were living 80 miles away from the nearest birthing hospital, I would be a wreck, just nervous. So that's important to consider as we're caring for these patients, and what additional support might we be able, we can't build a hospital right there, but what might we be able to do to support them? Are there different telehealth opportunities? The work that all of the doulas and birth workers across the state are doing, all of that, I think, is really kind of moving the needle on these the perinatal mental health conditions as it relates to access to care. So you can see here that those, when we're evaluating perinatal mental health resources, the communities in Montana with the greatest risk have the lowest resources. And I told Lynetta earlier that I was going to call her out. I had the opportunity of visiting the One Health Clinic and some work that she is doing in helping connect birthing people into getting medication therapy for opioid use disorder is really remarkable. So everybody should probably clap for her now. I mean, I think, and it's not to say, I'm sure that there are multiple people in this room that are doing a lot of that really great work. I just haven't heard it, so come up and tell me, and maybe I'll be invited back and can announce it next time, or we'll tell anybody and everybody who listens to me. But I just want to point out that the work that you all in this room are doing is really moving the needle on this access to care. Again, I also wanted to show mental health providers, and the one note that I want to make here is that we have some communities like Lake County, for example, has maybe the lower. There's fewer patients to every mental health provider in that community, but does that actually mean that that provider can see those patients? We don't know. So some of the work that we're doing at Blue Cross is trying to identify what does that actually look like in those communities, and we're also trying to work again to support primary care practices and clinics across the state in integrated behavioral health, advancing care teams, supporting all the work of the doulas and birth workers and community health workers that we're doing, or that you all are doing, so that we can try to help kind of close these gaps. And we're also trying to help identify any other types of telehealth resources or remote patient monitoring resources. What else might we be able to do to improve access to care in Montana? And I put some resources here if you need to find a provider or mental health services. Insurance status. I work for insurance, so I'm here to sell it. I'm just kidding. This is recorded also. No, but really though, insurance status, if we don't have insurance, we're not going to seek care. If it costs $20,000 to deliver a baby. Why would you go if you had to pay? I wouldn't go if I had to pay cash. So it is important that everybody in the state are insured, and that's with the type of insurance that meets their needs. It's not, again, I'm not here to try to sell insurance. And I know that there are people in this room also working really hard with all the Medicaid redetermination and helping to support patients across the state get insurance. We're trying to help support health systems in identifying, what type of plans do we have that might be able to help patients in those gaps. We're also trying to help educate patients who are uninsured on options for them. And then, I think probably it goes without saying that everybody, we need to be supporting ongoing Medicaid expansion, or this is going to get really bleak. There's a couple more here. I want to save time for questions, but a couple more things that are feeding into that vulnerability index. And, median household income. So just to point out, Jefferson County, which I was surprised about, I guess I'm not sure exactly what's in Jefferson County, but they have the highest median household income. That means 50% of the people in that county are making more than $83,000 a year. But we can see that in our more lower, our communities with lower median income and those with higher unemployment rates are, again, those most vulnerable communities. This resource, the County Health Rankings and Roadmaps, does an excellent job of recommending different types of interventions that we can do to try to improve these numbers, and oftentimes they're policy types of interventions. And again, One Health, I was up there visiting, but one thing that they've done, again, that's going to improve this unemployment rate is they have their drop-in center with computers where they're helping people apply for jobs, get their GED. That type of work is really remarkable on these types of outcomes. Again, I'm sure that there are places all over the state doing it. Please let us know where that's happening, because we love to hear it. Physical environment, when we think of physical environment, we think of housing. And so I put up here severe housing cost burden. And this isn't necessarily access to housing, it's how much of your income does it cost to afford a house. So I've circled here the counties with the highest housing cost burden, meaning that like in Rosebud County or Beaverhead, 17% of people are spending more than 50% of their household income on having a house. And I wanted to point this one out because this data is from 2022. I think we really need to continue to watch this as we see ongoing increases in housing, and also realizing that in our communities with maybe lower vulnerability, or in communities where, like Bozeman, for example, or Gallatin County, where we may not think about those communities being rural or at risk, there are populations in those communities who are having to decide between affording their house and getting medical care, and what can we do to try to help support that. Last one about physical environment, which is my favorite thing to talk about, that we don't always think about when we think about physical environment, is the information environment. So information environment is our access to broadband internet, access to libraries, and access to local news outlets. So this top graph here is access to broadband internet as of 2022. You can see we have counties in the state that 32% of the people in those counties don't have access to any broadband internet. And that's not, this doesn't mean that their broadband internet that the rest of the community has is fast enough to stream a telehealth visit. That's access to no internet. The graph underneath this it's probably, again, a little bit hard to see, but this is the quality or availability of the information environment. The darker the blue, the higher quality information environment. And then the lighter shading, the lower quality information environment. And again, it's taking into account number of news outlets, access to internet, access to libraries. We see that the counties with the lowest quality information environment and lowest quality access to internet are some of our more rural communities. And we know that historically and at present day, our more rural communities, those communities with lower income, communities that are experiencing racial discrimination, or our marginalized communities are less likely to have access to those things due to digital redlining, where the service providers might, intentionally avoid implementing service in those communities because of lower income populations living there that aren't able to afford the subscriptions. We know, like, everybody's like, well, who cares if you have the internet, or what about your information environment? We know that that's sort of how we stay connected to the world and how we learn and obtain information, but it also directly impacts health. Access to the internet helps us get more educated. It helps us get better jobs. It helps us be able to have a telehealth visit. It increases our access to care. It also increases our access to social supports and reduces social isolation. Like local news outlets are important because sometimes that's the only way that you might hear about a community event or different policies that might be impacting your community. And it's also important, and we saw this during the COVID pandemic, if your community has one local news outlet and that news outlet is presenting biased health information that might be false information, there's the potential for that community to sort of run with that misinformation from that news outlet. And then libraries. I think we don't talk about libraries enough, but they're a place where people can learn, they can get the internet. They're often a community hub in some of our smaller towns. But we have libraries closing across the state as well. So just keeping in mind that all of these things, while we think about housing and can we drive, how far away is it to get places, but the information environment, I would say, is equally, if not even more important than some of those other things. Because if you have to drive far, you don't have a car, but you also don't have internet, that further reduces your options to seek care. This is my last little plug here. So civic health is our ability to participate in our community. And civic health is really important. We know that communities with greater civic infrastructure, so those communities who have better internet, higher information environment, who have better housing, more social and economic supports, are generally more healthy communities. And a lot of the information that I've sort of talked about throughout are related to policy changes may need to happen for that infrastructure to improve. So I just kind of wanted to put here, civic participation is important, but we are in an election year. We do have some of our highest vulnerability counties with some of our lowest rate of voter turnout. And again, it's important if we're going to be caring for our communities, it's important for those communities to be voting and making decisions for their own community. So I put this up here, this link to this badge, which is really awesome. It might be a little late to get it now, because the election's coming up soon, but this resource also has multiple other resources that can help your patients get registered to vote. I can talk to them about where do they vote. There's like a whole free packet that you can download from that resource, and I would suggest that if you're caring for people, especially now, especially in these communities that have lower rates of voter turnout, that's a great resource to help you better be able to support the overall health of your population that you're treating.